Welcome to the 332nd of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today I talk with CECILIA Tomori about maternal and children's health in the midst of the pandemic. Just a reminder, you can usually catch COVID Calls live on weekdays at 6 p.m. Eastern Time. Just go to the COVID Calls YouTube channel to watch. You can also hear COVID Calls anytime recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can keep up with COVID Calls via Twitter using the handle @US of Disaster or @COVID Calls. Please help spread the word and send suggestions for future guests and future topics, and please feel free to suggest yourself as a future guest. We're scheduling COVID calls at this point out into October, and there are slots available. If you would like to come on and talk about current research, please do let us know. As of today, September 1st, 2021, there are 4,522,230 deaths from COVID-19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. I'm going to continue raising different COVID measures that I'd like to know about in addition to the death totals. And I've been asking guests to suggest ideas. And my guest today, CECILIA Tomori, has done so. So let me read a couple of COVID measures that she suggests. She'd like to know about the number of people with long COVID, children who develop long COVID, and numbers of mothers and infants separated during the pandemic. Also, infants not breastfed or not exclusively breastfed due to separation or lack of skilled support. So these would all be measures that would help us understand this pandemic. Thanks to CECILIA for that information, and we'll talk more about that in just a moment when I bring her out for the discussion. I've been reading a life story or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The title is Tributes for Nurses and Midwives Who've Died in Pandemic. This appeared the 20th of April, 2020 by Rebecca Gilroy in Nursing Times. I'll put up a link to this after the discussion so you can see. There are 10 brief obituaries listed in this news piece, and then I'll read 5 of them today and 5 tomorrow. Patrick McManus, 60, was a nurse for more than 40 years and died on the 19th of April, 2020 at Royal Stoke University Hospital. Originally from Ireland, Mr. McManus was described as an extremely well-liked member of the nursing team at Stafford's County Hospital, part of University Hospitals of North Midlands NHS Trust. Tracy Bullock, the Trust's chief executive, said he was a lovable character and brought kindness and compassion to all his patients, which was acknowledged by the number of compliments and thank you messages he received. He was an exceptional leader and took staff and students under his wing. West Midlands branch of the Royal College of Nursing paid tribute on social media, writing, "We're so sad to hear that nurse Patrick McManus has died, and we extend our deepest sympathies on behalf of the RCN to his family, friends, and colleagues. Rest in peace, Patrick, and thank you for dedicating so much of your life to caring for others." Linda Clark, 66, was a midwife at Royal Albert Infirmary in Wigan at Wrightington, Wigan and Lee NHS Foundation Trust. She had 30 years experience in maternity care and will be sadly missed by colleagues. The trust confirmed that Ms. Clark had tested positive for COVID-19 and had underlying health conditions. She died on the 17th of April, 2020. The trust posted its condolences on social media, announcing its great sadness about the loss of a valued member of their family. Linda Clark worked in our maternity service for 30 years, bringing many new lives into our borough, and will be greatly missed by so many. Our thoughts and sympathies are with her family. Brian Mfula, a lecturer in mental health nursing at Swansea University, died on the 17th of April, 2020. His students described him as having the biggest heart and passion for nursing. Professor Siri Phillips, head of the College of Human and Health Sciences at the university, said, "Students have described Brian as an inspiring teacher and role model who taught from the heart and had a passion for mental health and nursing." Colleagues from across the college have made reference to his generous spirit, his warm personality, and his highly infectious laugh, all of which made others feel good simply by being in his presence. His colleagues have also described him as a lovely man who will be sorely missed by themselves and his students. Mr. Mufula leaves behind his wife, Mercy, and children, Keto, Nkweto, Thabo, and Thandwe. Gladys Mujajati, 46, was a community mental health nurse at Derbyshire Healthcare NHS Foundation Trust. The trust confirmed that Ms. Mujajati had an underlying health condition and had stepped back from frontline duties in recent weeks. She contracted COVID-19 before dying in the hospital. Ifti Majid, chief executive at Derbyshire Healthcare NHS Foundation Trust, said staff were devastated to lose a much-loved team member. She said Gladys had a big heart, and colleagues have talked about how she always had a smile on her face. She was known to be a warm and caring individual, always looking out for her patients and colleagues, showing true compassion and empathy. It is clear that in Gladys we have lost a fantastic nurse, colleague, and friend. Michael Aliu, 53, was a staff nurse at Homerton University Hospital where he had worked since 2007. He was described as a key member of an acute care unit in East London. Homerton Chief Executive Tracy Fletcher said Michael was a vibrant, larger-than-life character on our acute care unit and was well known and very well liked throughout the hospital. He will be greatly missed by all his colleagues, both in the ACU and the wider Homerton hospital community. Our thoughts and condolences are with his family at this sad time. Obituaries of nurses and healthcare providers from the UK in the spring of 2020. Okay, let's turn to the conversation for today, and I'd like to introduce my guest to you, CECILIA Tomori. CECILIA Tomori is Associate Professor and Director of the Global Public Health and Community Health Program at the Johns Hopkins School of Nursing, with a joint appointment at the Johns Hopkins Bloomberg School of Public Health. She's a Hungarian-American anthropologist and public health scholar whose work addresses the structural and socio-cultural drivers that shape patterns of health and illness. Dr. Tomori has collaborated with colleagues at Johns Hopkins and beyond on breastfeeding, infant sleep, and infectious disease prevention. She's authored 3 books on breastfeeding and reproduction and numerous publications on a range of public health issues, including the COVID-19 pandemic, which we will talk about certainly today. CECILIA Tomori, thank you so much for joining me on COVID Calls.
Thanks so much for having me.
So I'd like to start the way I generally do, just finding out where you're calling from and what the situation looks like there today in terms of the pandemic.
Yeah, so I'm calling from Baltimore, Maryland, on the East Coast of the U.S. for international audience that you have. And I mean, the situation is not great. If we look at the entire United States right now on the CDC data tracker, you'll see that the entire country is lit up with high transmission. We've turned towards all the reds that they have indicated. So we no longer really see distinctions, on that map anymore. So comparatively, to some of the real crisis areas, we're not at that particular level here. But there are, of course, concerns about rising cases and, what's going to happen as the pandemic progresses, especially as the fall colder weather comes in and more people move indoors for larger gatherings. So, I think we're sort of at that stage where, depending on who you are and how much you know about the situation, you might have very different perspectives on what's going on, which I think is fairly characteristic of the United States in general.
Absolutely. What about the school situation there in Baltimore? Have they made some hard decisions yet about how to proceed?
Yes, I think that kind of conversation, is happening all around the country. I think there is generally a desire for returning to, normal, whatever that might mean. And so, most children are back to school already. And different counties, different school districts have taken different approaches to the level of measures that they're implementing. So there are efforts certainly to implement some measures, masking, for example, and there has been efforts to upgrade, the ventilation system, but, we still have issues around capacity, the quality of masks, the whether we have adequate monitoring, and of course, high community transmission. So I think in general, we're going to be struggling with some of those issues in the coming weeks. They just got started, most of the students. So we will have more on that, I think in the coming weeks. But, I think me, along with some other scholars, we can talk about that later. We've been very concerned about the level of attention or lack thereof to the safety of kids overall.
So I'd like to ask you also, thank you for that update, and just ask you also a question I've been asking folks in the last couple of months about memories of this time. Not that it's past us, but I wonder if you wouldn't mind sharing a strong memory or association of this COVID period.
Sure. I mean, there's of course more than one, but I think, in terms of where I get kind of directly pulled in, was last spring when we, along with colleagues, of course, and frontline healthcare workers, were looking at some of the guidance around maternal child health policies in the pandemic. And there was this sense of, oh, okay, we know what the guidance is in China. And we knew that mothers and infants were being separated. We knew that they were not being allowed to breastfeed. And I think everyone was sort of dreading what was happening next, based on what we already knew about how our public health agencies tend to respond. And I remember, at first when the recommendations came out from the CDC, where they said, they used this language that was like, we want you to consider separation of mothers and infants. And, my messages and my phone lit up immediately after that. So I think that's a pretty strong memory because, I was, watching certainly from a public health perspective, what was happening. And I was very, increasingly alarmed. But I think it was that particular moment that I thought, okay, what is going to be happening? And what are we going to do about it? And who is going to speak up about what's going on here? And feeling the responsibility to start doing something.
That is a concrete image of something being announced by CDC, particularly in your field.
Yeah.
Something that's announced by CDC, and the alarm bells
Yeah.
go off. And so I want to ask you about that. Sort of pre-COVID, how you got into the kind of research that you do.
Sure. So, I did not have an anthropology background in undergraduate. I was a fairly new immigrant from Hungary and didn't really understand, academic disciplines, as I think, is common among academics who don't have this kind of background. I didn't understand how these disciplines were even organized.
Sure.
And I grew up under occupation, behind the Iron Curtain. So the idea of being able to critique things as a social scientist, that was not really on the table in Hungary before, the 90s. And so I started becoming interested, in social science, but really didn't get there until graduate school. And, I think I was sort of fishing around. I had this degree in biology and I had a degree in education, and I was drawn to social science, but just didn't figure it out. And then finally, I ended up proposing something around, embodiment. I don't think I fully understood what that was. And around pregnancy and birth. I think partly because I was already interested in issues around gender, and I had done some health services research in an OB-GYN clinic in particular. And so once I got to graduate school, and we had a 4-field anthropology department, so very diverse, so we have sociocultural, biological, linguistic, and archaeological anthropology all under one roof. And I started encountering some of the work from both biological and social anthropology around birth and medicalization and all those things. And did some preliminary field work and ended up, with people talking a lot about, breastfeeding, a lot about sleep. And so I think I sort of followed the data, and followed the ethnography and started that work. So I really, it was more the project found me, I think,
Hmm.
than I was necessarily settled on something, before I got there. And so then I just ended up doing more of it over
Mhm.
time. So, ended up writing, my
Mm.
first book about breastfeeding and sleep, and then got more interested in the historical aspect of it. And then really, understood more about what the conversation was like in around these topics, and how much of it was determined by conversations in public health. So I realized I needed more training in that area, and ended up with a postdoc, actually,
Mm.
which is how I ended up at Hopkins. I did a postdoc in epidemiology and did a whole bunch of different work, much beyond breastfeeding, and sexual reproductive health, and all sorts of
Mhm.
topics. Um, and so, that training proved to be extremely helpful when
Mm.
it came to these kinds of things, because most of that work was in HIV prevention,
Mm.
various aspects, social, psychosocial aspects of it, and other topics as well. And so, when it came to the COVID-19 pandemic, I had sort of these pieces that I learned from different
Right.
disciplines, and could sort of bring them together to start thinking about what we needed to do.
Well, thanks for telling us about that. And I always find those kinds of stories are probably give, I hope, a lot of encouragement to graduate students who wonder how people get to the point where you are with your research, and it's not always a straight line. I also appreciate your observation about the challenges of learning what the social sciences are under authoritarianism. Um, to make that leap into anthropology, sounds like you had to also make the leap to a different
Absolutely.
environment. Yeah. Um, uh, could you tell a little bit about the methods that you bring to bear? What
Sure.
kind of what kind of techniques do you use?
I would say pretty, I mean, at this point, pretty interdisciplinary and eclectic. And I think in the beginning, when I was in graduate school, I mean, there's this whole part about, becoming the anthropologist and being the proper kind of anthropologist. So, I was a proper sociocultural anthropologist who also happened to, have a biology degree and do this other things. And I think over time, I realized that, maybe being a little bit eclectic and interdisciplinary is actually an asset. It's not necessarily that you need to be this, one kind of disciplinary person, which I think is sort of where the training takes you. So I really ended up using everything under the sun. So I'm a properly trained ethnographer. My study was a 2-year ethnographic study, so I checked that box, and I love ethnography. I think it's wonderful. At the same time, I think, for the work that I started doing after that, it was not necessarily the most useful, partly because if you want to be doing work, that is multi-sited, or, if you want to be in conversation with public health people, you really need, more team-based approaches and different kinds of methods. And you don't necessarily have 2 years to do your beautiful ethnography. So I think, in that regard, I've done all sorts of qualitative methods, particularly interview-based methods. And, sometimes I have to read interviews in translation because it's not, if there are multiple languages involved that I don't speak.
Mm.
So, definitely ethnography, but then also interviews, focus groups. And then over time, increasingly, as I became more comfortable after my postdoc, more mixed methods work, and having those kinds of conversations with colleagues has been really, really helpful. So, I had a wonderful group of experts that I could draw on, for posing particular questions, and I think I really enjoy that kind of conversation of
Mm.
multidisciplinary work. And even a little bit of archival work. So I'm really I'm I'm pretty eclectic. I do whatever it is that suits the question.
This problem of ethnography and time is one that I've heard a lot about on COVID calls in this, pandemic period. And I think about all of the researchers who had projects underway and they had to suspend them because of the health of the people they were uh, working with or their own. And then graduate students who are now like trying to ramp back up and get out into the field. And I know some of them. And it's when you lose momentum in a project like that and you lose trust and you lose the sort of cultural fixity of a place, it's incredibly challenging to get back into that moment.
Yeah, I don't, I mean, obviously, I don't envy anyone undertaking those kinds of projects now, and I think that the ethical piece of that is enormous. I think I would be horrified, if somebody decided to just, do this kind of exploitive research project and potentially risk people's lives, that they're interacting with. I mean, that's just unacceptable. Um, I think that in general, in social sciences, particularly in anthropology, it would be beneficial to us to equip students with a diverse range of methods so that
Mm.
they can draw on them because things happen, and they happened, even before the pandemic. I mean, I had colleagues who faced extraordinary challenges.
Sure.
So I think having an array of methods and approaches and different ways of getting at what you're looking for and being able to pivot is something that actually we should, do more of, for sure.
So establish the landscape for us a little bit, if you will, in the areas of your research coming into COVID. What are some of the main things that we know about maternal and child health care in disaster more generally?
I mean, I think one of the key issues is, and this is sort of what then shows up in the pandemic, it kind of gets accentuated, is how little we think about it, right? So I think, the general lack of attention, despite, more recent sort of discussions of it, but even though we say we prize these things, in the end of the day, in terms of how we approach things, even before a disaster around maternal child health, it's not a great landscape. It's a very the history of that, which is sort of where I started going in my later research, really just it sets the stage for the kind of problems that we have during disaster. So and it of course varies, depending on the context you're in, but in the US and, in many sort of Western settings, heavily biomedicalized birth with lots and lots of interventions and very much this fragmentation between care that's provided for the mother and the infant. So historically, there was this complete transformation where we went from, communities of people, usually midwives taking care of people, not always, but most of the time, and certainly knowledgeable people in the community would participate in the process of caring for people who are pregnant and postpartum, to this kind of dramatic fragmentation of, maternal and child health and different experts being in charge of those people. And so that fragmentation really structures everything, including how we think about things in our policy response and what happens in disasters. And so remember that, generally that group of people is not necessarily thought about to begin with. And so when you have a disaster, people often overlook mothers and infants, and the outcomes are terrible because the vulnerabilities of human infants are pretty grave. They actually are dependent, physiologically and evolutionarily on a caregiver. And so that not thinking and the not thinking about how the two people are interconnected means that it's very easy to undermine, some basic issues, including infant survival, which is a major one. And so in disasters, one of the major problems that we have is, for example, if a disaster occurs in a cultural setting where breastfeeding is the norm, then the Western NGOs come in and inadvertently, because they don't know, and they're coming from this very fragmented, problematic system where formula feeding has become the norm for many people. Their idea of, saving infants is to distribute formula, for example. And that actually ends up costing lives, especially, in disaster settings, where you may not have access to electricity or water. And certainly you're undermining breastfeeding, which was what was sustaining the infant to begin with. And so then you're opening the door to diarrheal illness. And it's just it's a terrible situation. So that's one of the areas that we have an undermining, people's confidence in their ability to breastfeed, rather than providing support to say, okay, you're in a disaster, it's terrible, but if you keep feeding that baby, actually you're going to be okay. That would be the other response. So that is something that I think a lot of my colleagues who work in, humanitarian health are working to change that kind of mindset. And the WHO has done a good job supporting that, but of course, locally, anything is possible.
So a part of what I hear you saying, and correct me if I'm wrong, is that the disruption or the transition from breastfeeding to formula feeding potentially has greater health impact in low-income settings. Is that
Definitely.
right?
And I mean, so I think,
why is that the case?
Right. So that's a big one. So I think one of the challenges is, we have to kind of think about the historical paradigm that most Western researchers have, which is the assumption that formula feeding is, how it is, right? And so, so thinking about more the evolutionary context of, human infant feeding, and, thinking about humans in relation to other mammals is really helpful. So these are, very ancient evolutionary adaptations that aren't just about food, but also about infection prevention, which obviously is going to come into play in a second when we talk about the pandemic. And so lactation and breastfeeding are the human evolutionary norm. And the formula feeding piece is a pretty recent invention in the past couple of 100 years. And it's increasingly supplanted the cultural norm of breastfeeding, in large part due to the influence of the formula industry. And so that is sort of the starting point. And so the health consequences are relevant for both high income and low income settings, but they're going to be more easily observable and more acute in settings where you have particular limitations. So obviously, clean water is a major one. The ability to prepare formula safely at the right temperature is another. Keeping the equipment clean, those are major issues, and they have been with us, really since the invention of this whole product, and the way in which the industry really, manipulates people to believe that these are great solutions, or that this makes people healthier, which is actually not true. So in a high income setting, so the tricky thing here in the US, even in general in high income settings, so there are differences in health regardless, even in the most ideal circumstances, simply because formula feeding is not the same as breastfeeding. But the differences are going to be much more acute in a setting like the US, where we have a profoundly unequal society. And so you're going to see that inequity, people who are already belonging to communities that have been marginalized, who are going to have, much greater disparities to begin with. And you have to remember that in the US, we don't even have, access to clean water in many communities. I mean, I don't think people realize that we have a really problematic water infrastructure. But it's pretty awful. And so, even just that piece is a big one. And then if you think about, the impact of various kinds of events like climate change, you have situations where, again, we're in the same kind of situation. Like breastfeeding is going to be a major factor in enabling the child to survive and thrive. And so those issues, unfortunately, they are quite relevant even here in the US.
One other part of that, just so I understand, because your observation that these issues we've been discussing have not much been discussed in the history of disaster preparedness, let's say, and
Right.
emergency planning. I, I wonder, I want to think with you a little bit about that. Is that because of some assumptions about how long a disaster lasts, and so planning for something immediate, event driven, quickly resolved, and so we're not going to worry too much about what might be a 1 week or 2 week disruption. So, which is for many people a misunderstanding of how long disaster lasts. Maybe
Right.
that's one possibility, or is it more of a gendered issue where it's just, well, these are just problems that women have, and we'll just let them sort that out. We need to focus on material and trucks and debris removal and things like that. And I'm really flattening, and I don't mean to do a disservice to my
Yeah.
colleagues in emergency management who've come a long way, I think, in this area, but they've inherited a set of emergency plans that they now have to bring up to speed to the research. So I guess I'm sort of curious to understand a little bit more deeply about this blind spot that you've pointed out.
I think part of it has to do, so there's several things. I think one is, that the history of fragmentation in responses, including the medicalization of life, as a whole, as sort of different things belong to different categories, which is, both medicalization and obviously an outcome of the general transformation towards capitalism that's also about fragmentation. So the two are running parallel.
Mm.
So I think that that's part of your answer, is simply they belong in different domains. So
Mm.
disasters occur in one domain, mothers and children apparently occur in this other domain. They don't belong together. I
Right.
think, clearly the lack of attention to this group of people has to do with other, issues around what we value and how we don't really value moms and infants, despite the rhetoric. So I think that piece, of the lack of value of people in actual pragmatic terms, other than the rhetoric, is another piece. I think there's also the issues around racial ethnic inequities. So whose lives do we actually care about? Who are most affected by these kinds of emergencies? Some of them are, long running, like, the lack of access to clean water and running water on reservations. That's it's like all about what you're talking about. It's a slow disaster, but we're not really addressing it. Why? Because of the historic inequity. So I think there's that piece too. I think all of the above. And I think that there is this, the other theme that, I'm sure we'll talk about, which is this sort of American individualism and exceptionalism, which treats these things in theoretic terms. So like we don't have these issues because we've overcome them. Right. So we're not really in touch with the empirical reality of how, large portions of the population live. And a lot of the people who are involved in some of these things come from very privileged backgrounds. So the people who talk about some of the things like infant feeding, in the media, tend to speak from an extremely privileged perspective, and they simply cannot conceptualize, what it would mean to have their lives disrupted for a long period of time.
Well, first, let me just remind folks you're listening to COVID Calls, and I'm talking with CECILIA Tomorri today about children and maternal health in the pandemic. And thank you for that discussion. I think it's incredibly useful one. And I think it also, if there's I don't know a trope that's more frequently repeated in popular culture around disaster than the sort of women and children first. Every disaster movie has a scene where defenseless women and children are shepherded into the boat first. And what you've said is that plays out cinematically, but if you look at the reality, it's they're then pushed out of the frame and forgotten.
Right. Right.
Let's turn to COVID and back to this moment where you were describing where your phone lights up and CDC introduces the idea that it may be okay for separation of children and breastfeeding mothers. And so what do you do? I mean, you're engaged in research, but you're also engaged in outreach and organizations that support breastfeeding. Tell us a little bit about what those first few months were like for you.
It was a little bit intimidating and overwhelming. I think I just did not expect. I was sort of looking to see, where is our leadership? And this may be a persistent theme, and I thought, shouldn't we be talking about this? Isn't this a concern? This is a major issue, thinking, I was looking at some of the data that was, early and preliminary, but we were seeing this clear pattern, with age. We're also seeing, and I want to make sure that we emphasize this, that it's not that we didn't know that there were potentially rare but severe outcomes as well. So you're looking at that, but then you're also looking at the larger age gradation. So you're holding both of those things in your mind. And I thought, okay, what is going to happen, when they recommend something like this? How is this going to play out? And where are the organizations that might speak about what the impacts would be, and under what circumstances would this really be a good idea, and what could we do differently? We know, I think one of the key issues in this whole story of fragmentation and medicalization is this pretty awful history that took place with the rise of biomedicalization, which was all about separating moms and babies. So this played out earlier in the 20th century. And one of the major outcomes of that was that in the United States, breastfeeding was almost completely wiped out. And that had to do with some of these protocols that hospitals instituted, which was all about separating moms and infants, and a whole series of other things. But that was one of the key pieces of it. And then undermining breastfeeding systematically and not allowing moms and babies to be together so that they couldn't really actually functionally breastfeed. And then enforcing that, for millions of people who had no idea that was what was going to happen to them. So we wiped out a generation of people who would have that cultural knowledge, and we're still dealing with the legacies of that now. So we have, decades of research on this. We knew how important proximity is. We know this, again, from comparative studies around other mammals as well. And we know it for, human infants, and how important that closeness is, and how important that closeness is for survival, for stabilization of the physiology of the infant, for maternal health, and for the successful ability to establish lactation. So it's really about systems that enable you to breastfeed. It's not about individuals making decisions and figuring this out on their own. It's about what is a cultural and medical system that facilitates it? What does it do to make it easy or break it? And so as soon as you start talking about separation, exactly, those of us who work in the field, we knew what was going to happen. It meant it's going to break that chain, and women are going to have a really difficult time establishing breastfeeding for their infants, and there's going to be lasting effects, and they're not going to be given the skilled support that they need to be facilitating breastfeeding. So there were a couple of people, commentaries that were written early on, but I didn't really see a lot of leadership step up. And so as I was talking to colleagues and, frantic text messages and, healthcare providers messaging me and saying, oh my gosh, we're seeing people being separated. Like everyone is being separated as a precaution, and everyone is assumed now to be COVID positive. I thought, okay, well, if no one is going to say something and we're not going to write about it, and the leadership isn't going to say, okay, this is a really problematic thing that's happening, I guess I should probably do something about that. And so we, out of those text messages and email messages, we ended up writing a paper about, why these processes are problematic and what kind of assumptions underlie them, because I really think it kind of has to do with this cultural defaulting back to separation when in doubt. That's sort of like our, 1950s and pre-1950s default that we keep falling back on. Wow. And then, trying to overcome some of these issues.
So, I mean, and just so I understand the context completely from the CDC's perspective, to the extent we can recreate it, I don't know if we can, but as you said, everyone was assumed to be COVID positive, and so therefore the risk is that the mother will pass COVID to the child.
Right.
And that's the sort of base assumption that then resuscitates all of this, as you said, sort of 100-year-old history of a process that was already sort of the muscle memory was there.
Right.
And were there other concerns, or is that documented that that's what they were worried about? Do they have evidence for that? I mean,
Uh,
coming from, by that point, there were 2 months from other countries. They could have looked at what was happening in China or
yes,
Italy or Spain or
it
other places.
would have been good. But no, I think so. There were several things. There was the early guidance from China. So I think they were also drawing on that, so that default, the idea of separating comes from both sort of a somewhat outdated biomedical system that migrates, elsewhere. So those kinds of issues in Chinese maternity systems are also a problem. It's not, it's not only the US, but that those assumptions were exported widely around the world. And some of them stay on, they linger longer, and then the other reasons for that have to do with people's experience, with prior pandemics. So I think that people were responding in that kind of frame, but the CDC went with that kind of individualist interpretation of mothers and infants being kind of separate versus the WHO that was very clearly saying, you really need to think about what are the foundations of maternal child health, and proximity at the center of it. And also, human rights. Like, what are the rights of birthing people? What are the rights of the child? Everybody deserves support during birth. Everybody deserves support postpartum. Babies and mothers belong together. I mean, these are sort of fundamental issues in WHO guidance documents.
Right.
The CDC does not always engage with those documents. And so it's this very, very individualistic framework, which keeps coming back. And then it was really individual hospitals that then started tweaking the implementation of that guidance. So the CDC actually tried to temper that a little bit and talk about shared decision making. But then the AAP, which is the Academy of Pediatric, the society that is in charge of pediatric medicine, they actually came down very hard and said, actually, we need to separate. And that was even later. So that actually happened later in the spring. I know, despite all, so in the meantime, the WHO says, really, like, we really mean you need to keep mothers and infants together. The British societies are also saying we should keep mothers and infants together. And instead, we have the AAP that says, no, we're gonna go ahead and separate because we're really concerned about the potential impact of transmission on infants. Again, which I think we're all concerned, like all of us were concerned. Sure. It was a question of what would be the best way to balance those considerations and try to keep people healthy and try to keep them from transmitting the virus to infants. I think at that time they were still concerned that it would also transmit through breast milk, which was not really ever a major consideration. And nobody really expected that to be the case based on the data. But there was actually kind of a heated call over the summer in 2020, where the AAP was defending their stance for separation. And they had a series of experts who were supportive of separation. And then they ended up having one of the experts that they asked to present, they actually cited our paper and said, actually, we think it's not such a great idea, to separate moms and babies. And eventually the guidance was reversed for both for the AAP and for the CDC.
So the paper is When Separation is Not the Answer, Breastfeeding Mothers and Infants Affected by COVID-19. And I put the title up here. People can find it's in the journal Maternal and Child Nutrition, and it appeared the 26th of May, 2020. And what you're describing, others have described, I think, very well as the shifting frontier of knowledge about COVID and what's moving very quickly. But it's not as if new information about COVID lands and it lands in a society that already exists, right? And so there's already these fault lines, there's already these presumptions about the right way for maternal and child health to proceed. So I think you've really established that quite beautifully. And just want to come back to this because I wasn't aware of this conflict. But again, does the AAP, when they make that recommendation, do they have some hard evidence to point to that there was significant risk of transmission of COVID from mother to child in the United States by that point, or other places, or what was the basis for that discussion? And which is particularly relevant because then they reverse it. So then they have to go
Right.
back and reevaluate whatever basis they were laying down in the
They
first place.
they really, I think at that time, they didn't really have the data. I think what they were saying, and and again, I don't want to seem cavalier about the risks, because I think that they're important to consider. So it's not that. What they wanted was sort of trial evidence that they did not yet have to be able to make that recommendation. So they just default to the idea that separation is safer. That is their paradigm. Separation is safer, even though they have now, in the last few decades, they have bought into the idea that actually, moms and babies together is the norm and that we should be advocating for breastfeeding. But the American Academy of Pediatrics doesn't have a particularly great history in supporting breastfeeding besides saying those words. Historically, it has not been particularly great at supporting breastfeeding, and they actually have considerable infant formula funding at the moment, active. So I think that there are some concerns about the actual material support and the knowledge of pediatricians about lactation, as well as other physicians who don't they don't have a lot of training in lactation. So there is kind of a not so great history on that part. I do think we have strong advocates who have really looked at the data for why the sort of, again, what is the human infant default, and kind of question some of those cultural paradigms. But I think that for whatever reason, and I can't tell you, what was going on in the head of those who wrote the papers around the guidance, but I do think that they knew it was going to be contested when they put it out, and they certainly received a lot of, there was a backlash against it, and again, the WHO and other medical societies who had been looking at the data strongly disagreed with that kind of approach. So I think it's just sort of where are the priorities and what are the defaults, and what do they consider to be more valuable in the end of the day. And lactation isn't at the top of the list.
So just let's bring it up to the current day then, and with the Delta variant, which has changed so many people's thinking about use of masks. I mean, a lot of public health advice that was given in the spring of this year, 2021, has now had to be reevaluated around social distance and masks and gatherings and every other aspect of the kind of way we cope with COVID infection because of the transmissibility and infection rates of Delta. So does that at all impact the paper you wrote or your thinking about the degree to which separation is not the answer?
So I think a couple of things. One is that, it never fully stopped. So once you have guidance that's not great, it's very difficult, as you can see from other kind of guidance, it's difficult to reverse it fully. So even though, hospitals are no longer ostensibly supposed to be separating, I'm still hearing reports, through messages from colleagues about justifications for separation. So that's still happening, and was happening well after the reversal of these policies, unfortunately. What has improved is, we have better access to testing. So not everybody is assumed to be positive necessarily, but, now we have obviously a much more complex situation than we had before. In terms of, considerations, I think one of the things that hasn't changed for me, and that has never been fully considered by the AAP or some of the considerations, is that when you take an organism that's dependent on the mother, right? They're part of a dyad. We call it a dyad. Then, infants are not independent entities. They can't actually survive on their own. So other people have to handle them a lot, right? And so that actually takes so there's other people who also are considerations in an infectious disease kind of plan, meaning that healthcare workers could be a source of transmission as well. So, I think that piece has never fully been thought through, that, there's this, the number of people who may be handling that infant, the amount of staff resources that it takes to deal with infants who are elsewhere. And then, of course, that they go home together, right? They get discharged. And there's other people around them. So I think that the key piece there is, based on what we know, and we have a lot more data, and the AAP now concurs that we can keep mothers and infants together, and that has substantial benefits. And really, I shouldn't be using the language of benefits. It's the default, right? Mm-hmm. So separation has risks. But I think that the piece that's sort of difficult now is, what to do in a situation where, the pandemic is raging, and you're going to end up with things like lots and lots of transmission, lots of pregnant people who are very ill, and in those kinds of cases when somebody is on a ventilator, they may not be able to care for the infant.
Right.
Which is terrible. And then we also have, transmission from healthcare workers as well to mothers and infants. So, I mean, there's just, the kind of scenarios that are happening right now are really terrible for everyone, and particularly for vulnerable people like pregnant people and infants. So it's really not a good situation at all.
What's the most recent thinking about vaccination for pregnant mothers?
So this is actually one of the key areas, I've been doing a lot of outreach around. So I was doing the academic work, and then I was also doing lectures for lactation organizations, and then community outreach and Q&As for, all the people who are lactation professionals and, midwives, doulas who are serving communities. One of the things that I think we really had a difficult time with is, because pregnant and lactating people were not included in the initial clinical trials, there was this question of like, what are we going to say to people right in the beginning? And lumping them together, which is a mistake. Physiologically, pregnant people are not the same as lactating people. So there was never really any theoretical risk that could take place with lactation at all. But again, without trial data, people felt kind of uncomfortable. Over time, we also have clinical data for both of those populations. So the sort of recommendations could be strengthened. And thankfully, what we're seeing is excellent safety profile for pregnant people as well. But because of that delay, we have this absolute terrifying inequity. And we didn't really know the extent of the inequity until this spring when we had more data on it, which is that only a fraction, like a quarter of pregnant people who were registered in the VAERS system, and remember, not everybody registers, so it's only a fraction of a fraction who were vaccinated during pregnancy. And that is because of this, again, the same kind of thing that we started talking about, which is completely overlooking this group of people, right, who should have been included in the trials in the first place, right? So we could get vaccination to people who need it. And if you think about it, pregnant people, like, we should probably be thinking about them, and lactating people who have infants who cannot be vaccinated, like, shouldn't we be thinking about them too?
Right.
So this is the result. This is the result of when you don't think about these groups of people and you don't integrate them into disaster responses, you have these profound inequities. And then, of course, within the inequity, the larger inequity, there's the inequities within that group, like the racial ethnic inequities in reaching particular people, which is the same, across the pandemic. But the costs, for pregnant people are lethal,
So the vaccine trials are usually not done for any kind of vaccine, are usually not done on pregnant
So
mothers?
yes,
It's just a gap in the, it's just a population that's out there that we just hope for the best.
And lactation too. Yes.
I don't understand that.
So it has to do with this history, which, there are some positive reasons for this, which is that, people don't want to exploit vulnerable populations, and pregnant people are considered a vulnerable population. And depending on the setting, lactating people too, usually. And they're kind of collapsed. And some of that, has to do with unethical research practices, right?
I
So we don't want unethical research done to pregnant people or lactating people. Absolutely, right? We're all on the same page. However, excluding them means
Yeah.
that they don't have access to support. And in a pandemic, that kind of makes an enormous difference. And we knew, by several months into the pandemic, we started seeing the data that pregnant people were having a greater likelihood of complications. And that data have strengthened over time. So it was absolutely stunning to see the consequences of this unfold. And, I'm still like, I look at that number and I'm just livid, because it means that people who could have had the opportunity to be vaccinated if they were given the information weren't. And some of those people are now dead. It's, to me, that's inexcusable.
And the concern about exploitation is that people who participate in clinical trials are paid, and that pregnant mothers might be particularly vulnerable at that moment, but economically precarious, or we're not able to give full information to people in a clinical trial, and so there's some risk that's assumed. I mean, I just want to make sure
It's
that part of it's
multiple
clear.
There's multiple different ways that ethicists have looked at this,
Mm,
but I don't think it's just about necessarily payment. It's about the particular vulnerabilities of that person. So if you think about potential harm to the pregnant person and their fetus,
right.
that automatically puts people into a different kind of category.
I see.
And that's sort of how often lactating people are thought about as well. But the interesting thing about vaccines is that the only concerns that we ever had with lactation were, live vaccines. So, if there's a concern about transmission, that's a totally different scenario. But there was, since these vaccines were not live vaccines, that was never a concern. So it was never clear, why pregnant and lactating people were lumped together to begin with. But getting messaging out to pregnant people, how do they make decisions around these issues? What about people who are breastfeeding and they're worried, what's going to happen? Like, can they transmit some part of the vaccine?
Mm-hmm.
There was not the kind of answer that we would have liked to have, which is not, there's no theoretical risk, right? Would have been really nice to have the hard evidence that actually, what we anticipated, which is how this whole thing works and why breastfeeding is, life-saving, is that, there's an antibody response, there's a strong immune response, and you are able to pass some of that protection on to the infant. So, if anything, that's we don't know the degree of protection per se, but we do know that lactating people pass on protection, and that can make a difference. So, we should never have, discouraged people from having it. And thankfully, like I said, we have actual clinical data now on all of the above and a great safety profile. So if you're listening and you're pregnant or you're lactating, please get vaccinated because it can save your life.
Are OB/GYNs giving that advice?
Yes. So that actually, once the data actually, OB/GYNs were really good about the vaccination piece, getting out earlier, but obviously not effective from the data in terms of the level of outreach, but they did try, and they've strengthened that recommendation over time with the growing body of research. So they have been recommending it for a long time. And the CDC made a very strong recommendation not that long ago, just a few weeks ago. So they actually had it on their homepage and tried to get that message out, and were, telling providers to strongly encourage people, not just to say, you can, it's great, it's out there, but like, you really should consider getting vaccinated because of what we're seeing with the rate of complications for pregnant people in particular.
So at any given time, this is not meant to be like a trivia question, but I'm just curious, at any given time, like how many pregnant mothers are there in America?
That's a really great question that I'd have to Google.
Well, that'll be a conversation for another time. But I mean, the
but
point is,
it's a lot. Yeah.
I mean, everybody stop right now and think, do I know somebody who's pregnant? Most people will.
It's a huge percentage of the population who's pregnant or breastfeeding, right?
That's a mother and at least one child, presuming most are not carrying twins. I mean, this is not some, again, from where we started this conversation, this is not some peripheral segment of the population. And so to
Right.
assume that we don't need to do the trials or that we don't need to worry about the advice is once again, I mean, it speaks to a much more distressing kind of cultural blind spot around health for women and children that is now playing itself out in this way. And I just want to point out, and there's a brilliant new piece in the New York Times. I know people get tired of reading about COVID, but you really should read this op-ed that Tara Haley, the journalist Tara Haley,
Mhm.
who writes so wonderfully about the anti-vaccination movement as a political
Yep.
movement and as a political strategy. And she has a piece that's up in the New York Times right now. And I hope you know her, or we should find a
Yeah,
way for
I
you two
do.
to
She's
talk.
great.
And she points out that, to bring this back to what you and I were just talking about, that the minute, I mean, under ordinary conditions in the United States in the last 20 years, there would be an anti-vaccination discourse going on. And you might even
Mhm.
say, in a democracy, we could tolerate some of that. Maybe that's even healthy to have a wide range of views. I don't know. Maybe many doctors and public health researchers might not agree with that. But now there's a segment of our political culture that's invested in that because they're benefiting by it electorally or monetarily, and
Absolutely.
usually both. And so what you've just
Exactly.
been describing is hugely distressing, because now there's an opening to drive the anti-vaccination message to pregnant mothers, and it sounds like
Yes.
it's happened.
That's exactly what happened. So when you have it's an opening, right? So when you don't have information ready, I mean, even when you do, you can see what you can do with it. Like misinformation and disinformation are what's driving, the pandemic, in large parts, not all, but in significant ways. And fertility and children have been huge tropes in the anti-vaccination movement for quite some time. They're very easy to exploit because, again, the cultural narrative is that we value these things. Again, not necessarily an empirical reality, but we like the idea of it. And so that gives people the opportunity to step right in. And I saw it, obviously coming, but I honestly I don't think anyone could see how bad it was going to get, how quickly it was going to get bad, because we had such a huge lag of time. So we went from, vaccines are coming, for the general population. And then, oh no, what about pregnant people? What about lactating people? What are we going to say to them? Sort of at the last minute. And then months of sort of, well, this is what we can extrapolate. I mean, that's just not good enough, And so that was exactly the springboard for misinformation. And so I've been dealing with that since, it's the same stuff that gets circulated, and and it's exactly like Tara describes, and others, like Peter Hotez, all the,
Yeah.
it is basically the same tropes over and over again, hitting those vulnerable points and twisting things around so that people fear the vaccine more than the disease.
Yeah.
And it's, the consequences are deadly. And it's just, it breaks my heart to watch, pregnant people on, on ventilators and ECMO and dying and leaving, infants behind. I mean, it's just, yeah, it's horrible. I did look up for you the
Oh,
number of
every
people.
time I talk to a public health, but it's just like talking to my colleague Esther Chernak. You ask her a question, and if she can't answer it, she's working on the side to answer it, and then she
Well,
comes
yeah,
back with the answer.
I feel like I didn't know the answer for you. So the estimated, this is on the CDC site, the estimated number of pregnancies dropped to 6,369,000. And I don't know what year that was, but that gives you a sense. I mean, so we're talking about millions of people.
So 12 million people, if you include a mother and a child in
Yeah.
that
Yep.
discussion.
Yeah. So it's
6 million mothers.
inexcusable. It's
Yeah.
inexcusable what we've done. So there's a lot of left behind groups, as you can, see. And I think that, that was definitely the motivation for me to think about, the pandemic more broadly too, is I was watching people being overlooked,
Yeah.
every day.
Just a reminder that you're listening to COVID Calls and my discussion today with CECILIA Tomori. And we have one more issue I want to get to, and I've been pretty greedy with your time today. Can you spare another 5 minutes?
Sure, absolutely.
Okay, so you also published I don't know how you're doing all this work, but a piece in eClinical Medicine titled "Your Health is in Your Hands?" question mark. And this piece, I just want to give just a small quote from it, a taste of it. You highlight in there at the beginning, sort of the setup is current CDC Director Rochelle Walensky's phrase, "Your health is in your hands." And the problem, particularly of CDC messaging, which seems to address public health as something that an individual can, that health is somehow individual and that public health is somehow separate, or it's not addressed what that should consist of. And you were motivated with colleagues to take that on and write about that. And so that's kind of been a theme running through everything we've been talking about today. But why did you want to write this op-ed? And maybe you could do a better job of summarizing it than I can. But it appears in the Lancet, and this is one of their many, many publications. And I'm going to put the link up here. Tell us about this article.
So, not unlike, when my phone lit up last spring, I think as we were watching, I think many of us working in this area, especially in health equity, we were watching sort of a shift in dynamics. I think we were all very hopeful when things started getting, more proper attention from the new administration, and we were no longer sort of saying, okay, we should just let everybody become infected. So I thought that was, wonderful. And we saw this beautiful vaccination initiative, but then we started getting concerns because of the way in which the rollout was occurring, and the sort of what I think many of us perceived as not enough attention to communities who are particularly marginalized, overlooked, who may not have access, to transportation, or who may have disabilities. I mean, people who really needed the vaccine brought to them. So I think that was a concern, and then started hearing more and more emphasis on sort of individuals over time. And I think that shift took place sometime in the spring. And then as the vaccination effort was, reaching its peak, and still, we barely got approval for the adolescent group. So, had no time to really, vaccinate folks. All of a sudden, we have this sort of celebratory tone, a new celebratory tone.
Yeah.
And then, the idea that people who are vaccinated can remove their masks. And I remember seeing that announcement and just my heart kind of like skipping a beat and thinking, oh my gosh, this is going to unleash, this cascade of events where is going to be taken like a green light, for, not just the people who are vaccinated, in fact, but for everything else. And I mean, it started playing out exactly like that. And so as I saw it, I started reaching out to colleagues, and, I think it was one of those messages, I don't know, midnight or something. And I said,
Mm-hmm.
we have to say something about this, because it's really this is not okay. And we need to write about it. And, would you be interested in working together? And, all these amazing co-authors, and I just want to, make sure we emphasize that all of these are all team efforts. It was a privilege to be able to lead that piece, but I mean, everybody on that team is incredible. And, I tried to reach out to a diverse group of people working in different kinds of pieces, with different kinds of expertise. And I was particularly interested in, centering health equity and human rights, which I felt like was a completely lacking, discussion altogether, and ideas about, history as well.
Mm-hmm.
And so that's how that team came together. And then, we worked really hard to try to sum up, thousands of words of, things that we had to say into this very tiny little commentary. But that, that was sort of the evolution of the piece. And really, we wanted to bring back the conversation. Like we felt like we really needed a reset, that this was all together going in the wrong direction, that this is contradictory to what we do, or what we at least aspire to in public health. And that, we do actually have guidance about what we should be doing, and human rights are a foundation to that. So we needed to bring back those kinds of conversations and prioritize, collective responsibility, not individual responsibility, and health equity and human rights. And we try to make our case, through the commentary.
I just want to give one more quote from the piece because it's such a statement on our times, too. You write, securing public health does not merely reflect the health of many individual persons, rather a collective public good that is greater than the sum of its parts. Public health actions protect and promote the health of entire populations through multi-sectoral interventions to address underlying determinants of health. And I remember that time as one where the CDC advice came out, and then President Biden said by July 4th, we'll all be in the backyard enjoying a cookout. And, that had incredible cultural resonance with people because they've been locked up a long time and they miss their family and they miss doing those kind of mundane things that we all used to complain about. Like, I don't want to go see my family. And then it's like, we got to do this. Like, becomes so important. And what strikes me here as I read the piece, and it's really provocative because it's speaking about public health, but also just about where we are as a country in the United States, and not only in the United States right now, is that there's so much rhetoric around individual freedom in this moment. I need to be able to decide for myself. Will I wear a mask? Will I be vaccinated? But almost every one of those cases, when you let people talk long enough, they're like, I want to do this individual thing because I then want my kid to go back to a public school, or I want to go to a public park and have a barbecue, or I want to gather with a big group. So the individualism it slips through people don't want to do these individual decisions so that they can go stand alone on a mountaintop and be healthy or unwell. They want to do it so that they can re-engage in the commons. But you don't get that option. I'm ranting now, but I was so motivated by the way you framed it in the piece. And it sounds like that's the kind of logic that you're trying to demonstrate, but it's so hard right now.
I think you're absolutely right. I think this also shows, that recurrent theme. I was thinking about, what is the connector between the different pieces of work that I've been doing? And I think this is it, like it's about cultural ideologies are ideologies. They're tropes, they're
Right.
kind of the recurrent themes that get pulled. It doesn't mean that life is aligned with them. It means that certain ideas become dominant. And then, powerful interests make them further dominant, So I think that is sort of the key issue, is that in reality, individualism is, it's always been a fairy tale, because our lives are interconnected, they're social, and we depend on one another for survival. We are a social species through and through. Everything is about the social. So the idea of individualism doesn't reckon with the actual reality on the ground, but it is a strong cultural trope and a dominant one that keeps getting reinforced, by people in power. And unfortunately, the other sort of ugly side of this is the moral culpability. So we also then assign blame. So if you don't do it right, whatever that is, then it's your fault. So there's that blaming piece of individualism that I think is really important. And then also that, we can hide our collective responsibility. We hide and erase the actual experiences of people and real people's lives in that process. So if it's about individual responsibility, we do not have a collective responsibility as a society or as a government, as a state, for ensuring that people are safe. What does that mean? Whose lives then get valued and whose lives become expendable? And I think that was a core piece in our commentary that we really wanted to bring forward, is that, in these discussions and how that narrative gets framed, there's this underside, this undercurrent of erasing needless suffering and death that's unfolding at the moment. And I think that's really where we are in the pandemic, is this sort of cognitive dissonance between the rhetoric of, particularly elites who keep saying that we're like emerging from the pandemic, we're post-pandemic and everything is great. people who have protection, people who, are vaccinated and they're really wealthy and they can work from home and they're doing their thing. And then, people who are continuing to die and people who are being overlooked, people who have children under 12 right now, in unsafe educational settings and childcare settings. I mean, whose experiences are being highlighted and whose experiences are being sort of erased in the narrative. I think that was something that we really wanted to draw attention to all of us, and we still talk about it.
Just want to remind everyone you've been listening to COVID Calls, and you can catch COVID Calls most weekdays at 6 p.m. Eastern Time. Please join me tomorrow for my discussion with Ashley Shu, and we'll be talking about COVID and disability justice and disability rights. And I want to thank my guest, CECILIA Tomori. And I have kept you from your dinner substantially here, but it was a great conversation in which I learned a tremendous amount. And thanks for all the work you're doing in your research, but also in educating the rest of us, and keep it up.
Thank you so much.
Stay healthy, everybody. We'll see you tomorrow at 6 o'clock.